Welcome to the Drug Medi-Cal Waiver Overview webinar, presented by the California Institute for Behavioral Health Solutions and the California Department of Healthcare Services. I now turn it over to Dr. Will Ratmersco.
Good morning, everyone. I'm an Associate Director at California Institute for Behavioral Health Solutions, and I'm helping facilitate a series of technical assistance opportunities that we have that we're offering this winter and spring around the Drug Medi-Cal waiver. Some of you participated in a regional meeting that we held back in December. The content of this webinar is essentially the same. The intention was to provide an overview of the Drug Medi-Cal waiver as far as we know it at this point. And so we really wanted to follow up with an opportunity to provide a webinar version for people who could not travel to a meeting and hear about it. And also by recording this, we hope that then you can distribute this to, it will be accessible to anyone who wants to know and have more information about the Drug Medi-Cal waiver. And so we also will be covering other topics. We have a few more webinars, and we'll be sending to everyone out the schedule once the of the other upcoming webinars are related to the webinar, and some will be targeted to particular audiences. And our next, and then we'll end with a regional meeting that will be focused on training on the ASAM criteria. So all that is more to come, and just look out for additional information that we'll be sending with schedules about those activities. So again, the purpose of today's webinar is just a general overview, and I'm pleased to have with us Victor Kobler. He is our Vice President at the California Institute for Behavioral Health Solutions, and he was formerly the Executive Director of the Alcohol and Other Drug Policy Institute, which was a nonprofit organization dedicated to advancing the substance use disorder field in California through training, policy analysis, and development of effective solutions to alcohol and other drug problems, working both at trying to address issues at the practitioner levels, the program levels, and system levels. And he's had a lot of experience providing technical assistance and being a consultant both to provider organizations, providing services to provider organizations, as well as county systems and for the state. So we're very pleased to have Victor provide this presentation. So Victor, welcome.
Well, thank you, Will. I'm glad to be here this morning. I see we have a very good turnout. What I'm going to talk about today are, as I say here on the cover slide, the challenges and opportunities presented by the Drug Medi-Cal Organized Delivery System waiver. And I think this is really something unprecedented in our field, and I've been in it for a long time. The opportunities this presents to together with the ACA and the Medi-Cal eligibility expansion, the opportunity it presents to really help design our systems in such a way that they do what we have always wanted them to do. And so I will go through this, describe what the waiver is about, kind of both technically as well as from an operational perspective. And so with no further ado, I will get started here. So first off, what it is about is expanding the availability of substance use disorder treatment for low-income residents of California. You know, those are the folks who either are eligible for Medi-Cal by virtue of program linkages like CalWorks, perhaps SSI disability, as well as under the income-only eligibility standards under the ACA. Many of these clients are in our systems already. Many of them are men. You know, we talk about the childless adult population. That's who they are. Many are also offenders. The waiver will enable counties, and counties are the administrators of the local Drug Medi-Cal system, and so counties will be the ones with the responsibility, as they have now, for administering their Drug Medi-Cal system of care. It's just under the waiver, this system will be much more robust than it is now. It will also provide for better management of client movement towards recovery and to maintain the gains achieved in treatment. and I'll describe how that will occur further on. I might add, DHCS distributed a request for counties to submit a letter of interest for participation, and that was due to them a couple of weeks ago. And 51 out of 58 counties returned that letter saying they were interested in participating. So that'll give you some idea of what the the county level interest is. What is a waiver? I'm not going to read all this. You'll have it. I believe May is sending this out to everybody, so you can just have it for reference. But what we're talking about here is an 1115 waiver. This is known as a research and demonstration waiver, and it's to test newer or existing approaches to financing and delivering services. That's what we're doing here. It also, this slide talks about managed care waivers, and there's some minor elements of managed care in this, but it is not, strictly speaking, a managed care waiver. Key elements of this waiver, I might add too, that the drug Medi-Cal waiver, strictly speaking, is an amendment to the existing healthcare bridge to reform waiver that we've had for several years now, and which is expiring at the end of October. The amendment is been submitted to CMS, the Centers for Medicare and Medicaid Services. It's a federal agency responsible for administering Medicaid, which we call Medi-Cal nationally. And they have 120 days to review it, and I believe somewhere around mid-March, the 120-day point will be reached. So we should find out in 6-8 weeks or so. So presently, the key features will be, and as I say, because the waiver hasn't been approved yet, CMS may want to see some changes. These are likely to be minor because DHCS and CMS have been in communication throughout this process. So there's nothing in the waiver that's going to be, a surprise to CMS. And then, in addition, there will be a terms and conditions which may add further detail, and also then a contract with counties specific to waiver performance, which will have all sorts of other requirements in there for example, data collection, participation, the evaluation, that sort of thing. So what we're getting here is just sort of the high points, and more detail will be forthcoming as we move towards implementation on these specific elements. So first off, and this is something that both CMS and SAMHSA are very interested in, is the use of the ASAM criteria. What used to be called the patient placement criteria, but use of ASAM for initial placement and transition to the appropriate level of care. And that will be, and that is typically, although this will be much more structured, a way of determining medical necessity. The issue is, does the patient have the disorder? If they do, yes, then what level of care, what type of treatment do they need? Residential treatment will be reimbursed. I think many of you may have heard about the IMD exclusion and the ban on Medicaid reimbursement for treatment at residential facilities more than 16 beds. The state will have the authority to reimburse for residential treatment up to 90 days. Counties will have the authority to select providers. This means that counties can do an RFP and select drug Medi-Cal providers on the basis of performance and quality standards. These performance and quality standards will also determine the continued contracting with these providers. Right now, under federal Medicaid law, the principle is any willing provider. Under federal law and regulation, anyone who wants to get drug Medi-Cal certified to be any sort of a healthcare provider can do so. That certainly, from the federal perspective, they are not guaranteeing that you will be successful in that endeavor. But That will change under the drug Medi-Cal waiver, and providers will be selected by counties. Drug Department of Healthcare Services will retain provider certification authority. That is a responsibility that they've been delegated under federal law, but counties may also have a role, and there's discussions around this right now. What can counties do? What authority must the state retain? Other elements include MOUs with health plans. These exist for county mental health plans with the primary health care health plans in counties. And so now we will have our own MOU, and this will cover issues relative to referral to treatment, care coordination, and things like that. It will establish a continuum of care. The counties that opt in will have to submit an application, and in that they will have to describe how they will provide a full continuum of care, and that would include things like medication-assisted treatment, and then I'll get into what those continuum elements are. The state recognizes that not all counties will have every piece of the continuum in place in every region of the county, and so part of that application requires a transition plan. How do we get from where we are now to where we may need to be? And that gap analysis will be part of that application. There is, so I said emphasis on medication-assisted treatment, requirement for the use of evidence-based practices. This was a recommendation. I'm not sure if you all know about this, but this, under the Bridge to Reform waiver, there was a requirement that the state conduct a behavioral health needs assessment. And one of the recommendations of that needs assessment was that the state and counties exercise prudent purchaser practices. And that was defined in part as use of evidence-based practices. If we're spending public funds, we want to make sure that these are expended on services that have the greatest likelihood of positive outcomes. Another element is the expansion of the role of licensed practitioners of the healing arts in assessments and other activities that's consistent with their scope of practice. So that means that, we would have things like physician assistants, LCSWs, others who could have a role in some of the treatment plan review and some of the early intakes. Now, physician has got to, there's some roles that the physician has to do, but, within scope of practice of other LPHAs, there's a role for them as well. We also have the reimbursement of, that's next slide. More elements. And before I get into this, the first one here is recovery residences. And that is something that's going to be funded out of the block grant. And the initial concepts for the organized delivery system included not only drug Medi-Cal services, but also block grant services as well. It's all one system at the county level. And however prescriptive the state may want to be with this, I think counties have a great opportunity to make their drug Medi-Cal system and their block grant system the same and something that's complementary. So recovery residences are essentially like transitional housing. It's clean and sober environment with supervision, and the clients would participate in outpatient treatment, whether that's regular outpatient or intensive, during the day. And this would be, I think, a way to help expand residential, or something that looks and acts a lot like residential treatment throughout the state. It's very difficult to get the new residential programs up and running with the licensure and particularly local zoning and NIMBY issues. And so this may be a good alternative. Recovery management services. When somebody completes treatment successfully, we've got everybody, the client particularly, but also providers in case have a big investment in that recovery. And so these are services that will enable us to provide recovery support and to make sure that we help retain the gains that clients have achieved in treatment. Another element will be rehab model service delivery, and this will, as they have in the mental health plans, permit reimbursement for services that are provided outside the clinic site, and also non-face-to-face services. Right now, Medi-Cal operates on the clinic model. Services provided have to occur at the certified location, have to be face-to-face. In this case, you could be with a client, say at a health clinic, if they're there for some healthcare services they might be needing, or via telephone. So this will be a big change, and I think really, particularly with social media and such, and I'll get into that a bit in a further slide, a way to keep in touch with clients and keep that connection with them, particularly after they leave treatment, so that they don't run into difficulties and relapse sort of in isolation. Reimbursement for case management, again, something we've wanted for a long time, and this will be, linking clients with services that they need, services of all kinds. And, the original concept for the waivers, as I mentioned earlier, is, broader than just Medi-Cal. And an early draft, it's talked about DUI programs is, level, what is it? I think it's 1.5 in ASAM for intervention. Now, certainly the waiver proposal only addresses Medi-Cal and Medi-Cal reimbursed benefits. So it doesn't talk about any of this other stuff, like the recovery residences, for example. So that will be up to counties and DHCS, guidance from DHCS, as I mentioned earlier, how we make all this money work together in a complementary fashion for the benefit of our clients. Financial provisions is and this gets pretty complicated, and counties who submitted a letter of interest to DHCS can request, and I think most have, technical assistance on the financing. So right now, DHCS is looking at a per user per month reimbursement mechanism for counties. There is also a fairly complicated cost-sharing arrangement. Counties are responsible for using realignment monies for some benefits. Other benefits will have state general fund reimbursement through DHCS. And also over the life of the waiver, the new benefits started out as 100% reimbursed by the federal government, and that will step down to a 90-10 federal-state cost-sharing arrangement by 2020, I believe. So in the life of this waiver, I think it takes a step in 2017 that there's, where the state or counties have to start contributing a little bit of matching funds. And like I say, that tops out at 10%. Counties will have flexibility in provider rate setting. This is my own question, whether this will provide the opportunity, this will be more fee for service, which we have now in Medi-Cal. You do the work, you get the reimbursement, which is volume-based financing, or will counties have the authority to establish things like case rates, bundled reimbursement, which is value-based financing. And I at least am starting to read more about, moving towards value-based financing in the healthcare system. We're paying for outcomes, not for visits. The sections in the implementation plan. So those are key elements of the waiver. I'll just go briefly the implementation plan so you can see what counties are going to have to provide in there. So those are the sections that are in the plan. So we start off with a waiver, the narrative, which discusses the service delivery system, what are the components, what exists now, what is in we coming online, how the counties will ensure access, and throughout all of this, I mean, a major principle on the part of CMS in any kind of waiver is that there must be no impact on client access to care. Ideally, that should increase, but it absolutely should not decrease. So counties will need to describe how they will assure access. This will happen both regionally, and I think there may be other dimensions as well beyond just, you know, drive time and proximity to bus routes. But, you know, do you have access for Spanish-speaking clients, for example? Counties will have to conduct quality assurance activities, and I think this will be a little bit of a change. Right now, drug Medi-Cal oversight is pretty much focused on compliance. Compliance will never go away, but you know, we need to take the next step up and be looking at quality. The implementation plan also needs to talk about the integration of services, not only with primary care, which we talk about a lot, but also with mental health. And not only for specialty care within the county mental health plans, but also with the health plans for services for the non-SMI populations they are now responsible for. A lot of assurances, you know, relative to things like access, et cetera, the county will comply with law in terms of the waiver. They'll have to describe the projected beneficiaries, so they'll be needing a fair amount of data here. You know, what are the projections for each modality? What are projections for each level of service? And this is, you know, not only, you know, who do we have in the system now who is Medi-Cal eligible but not being billed? And for example, we may have many people in residential care and some in outpatient, frankly, who are, you know, being billed with a block grant and not drug Medi-Cal. Say, for example, if the program isn't certified. So projections for each service modality and then each aggregating that up into each level of care, according to the ASAM criteria. Proposed rates, what would those rates be for each modality? How do they correlate with utilization projections? And then a justification of the rates. Everybody is hopeful that the rates will increase and actually pay for the cost of service delivery, as well as I think the increased clinical and administrative functions that both providers and counties will have under the waiver. But I think that, you know, the state is going to be giving the money away, so we've got to make sure we justify that very, very thoroughly. The benefits here are listed. We talked about the continuum, the organized system. So these are separated into required and optional. Starting with outpatient services, what we have is that outpatient services are comprised of outpatient drug-free counseling, which we have now, and intensive outpatient, which we used to call day treatment or day care habilitative, and that includes, so that would be, and then optionally is partial hospitalization, which would be intensive outpatient in excess of 20 hours per week. So outpatient is, I think, up to 9 hours a week, and then intensive outpatient is 9 to 19 hours per week of services. For residential services, at least one level of care is required. Additional ASAM levels are optional. And I guess, hopefully you've seen this now, but I recommend that everybody become very familiar with the ASAM criteria. This is going to be sort of, will provide the structure for much of how the waiver operates. Withdrawal management, at least one level of service. Now, this could be outpatient or residential, and additional ASAM levels are optional. Medication-assisted treatment is required. Recovery services are required. Case management is required. Physician consultation, as I said, this is, will be a work in progress for, until we actually get started. And so physician consultation at a waiver advisory group meeting a couple of weeks ago, the state indicated that would be a required service. And physician consultation, well, I'll describe what those are in the slides just up ahead. So anyway, that's the basic structure. So outpatient counseling then is the same as current benefits with some differences. It's fewer than 9 hours a week of service for adults, fewer than 6 hours per week for youth. Benefits would include family therapy, which we don't do now, patient education, which we may do now, and things like HIV and that sort of thing, but we don't get reimbursed for. Medication services within an outpatient program. Intensive outpatient, there's two levels here. There's 9 to 19 hours per week for adults and 6 to 19 hours per week for youth. And then, as I mentioned before, partial hospitalization is the 20 hours a week or more. And the services to provide in there, the state lists the specific services, and I imagine these are going to be, for at least outpatient, the covered benefits, talking about, a lot of what we do now in drug Medi-Cal, the, intake, treatment planning, collateral visits, crisis intervention, discharge planning, individual and group. We will have those, but also, they're meant talking about the case management and the other new benefits. And so the services to be provided in intensive outpatient are the same as those defined for regular outpatient services. Residential treatment, that is specified as a 90-day length of stay for adults, a 30-day length of stay for youth, with one 30-day extension for either group, which I think is pretty good. Other states, Massachusetts, for example, had residential treatments in previous 11 15 waivers that they had, and it was a 30-day length of stay for adults with one 30-day extent, either another 30-day extension or another 30-day episode per year. So this is, I think, is quite good. Other benefits such as withdrawal management, that would include, intake, observation, particularly in a residential setting, medication services, and most importantly, discharge services. We want to make sure, the clients aren't discharged from detox back to the streets. They are not discharged. Unfortunately, we still use that term, but we really need to be talking more about transitions, and they would transition to another level of care in condition to better participate in treatment, having dealt with their withdrawal symptoms. The medication services would include the prescription and administration of meds. Medication-assisted treatment. Now, this is this is both within and outside the waiver. But within drug Medi-Cal, we have methadone, we got buprenorphine, Suboxone, and disulfiram, antabuse. So those will be, buprenorphine and disulfiram will be new reimbursements within drug Medi-Cal. And in addition to that, we have the existing pharmacy benefits in what we may call regular Medi-Cal. These are naltrexone tablets. Generally, that's known under the trade name as Revia. treatment for alcoholism. There's now a Trexone long-acting injection. That's Vivitrol. For alcoholism, again, we've got a Camprosate, known as Camprol, and then naloxone for opioids. Recovery services. Now, these include recovery monitoring. I have to say some of this is outlined in the waiver. Some of this we may get more detail as we move forward to implementation. But, what exactly does recovery monitoring include? Like I say, we'll figure that out later on. There is assistance in getting into treatment if necessary, education and job skills, family support, support groups, and ancillary services. Again, I think the basic principle here is to help. Somebody's got to spend a lot of time in treatment. You spend a lot of time with that client, getting them clean and sober, and now we've got to keep them that way in the community. So I think a hugely important benefit here. Case management, this is, basically case management. That's assistance in accessing medical and educational, vocational, other services. Reimbursable services would include service plan development, client advocacy, as well as linkages to physical and mental health care. Now, these may be provided as, referring back to the rehab option, may be provided face-to-face, by telephone, or telemedicine medium, and may be provided anywhere in the community. So this is helpful. I mean, the clients don't have to drive out to the program. You could meet them, in a coffee shop or someplace that's more convenient for them. Other benefits include, I mentioned, the physician consultation services, which may be required rather than optional. But this will reimburse for consultation with ASAM or other addiction medicine specialists. Now, this is consultation requested coming from physicians, typically in healthcare settings, and then possibly also with psychiatrists and mental health programs. So consultation with ASAM or other addiction medicine specialists, that somebody's under care for, let's say, epilepsy, how does that interact with Suboxone? Questions like that, or psych meds, what might be interactions with addiction treatment meds. Counties are required to connect, would be required under this, to connect health providers with experts in the SUD field, basically not only to assist the client, but also equally important to build the expertise and comfort level within primary care settings for practitioners there, whether that's physicians, nurses, PAs, etc., to increase their competence in dealing with substance use disorders in their healthcare patients. As it says here, services can include consultation on medication-assisted treatment, medication issues generally, and level of care recommendations. Counties are going to have some new responsibilities, and these will include, as I mentioned, selective contracting, and within their county ability to select their specific provider system, which of course means that they may not select everybody who applies, or perhaps not everybody who is currently a provider, although that's implied. But they must retain client access to services. So at least, think of this at least on a geographic level. Literally, you've got to have the map covered. They must provide a continuum of care with the required services, and policies and procedures for selection, retentioning, credentialing, and re-credentialing providers. Now, this is something that's been a long-standing feature for for commercial carriers. You know, they've got requirements for enrollment as a provider, for staying on as a provider. And if any of you out there have done business with commercial health plans, you'll know what I'm talking about. Counties will have to authorize residential services. That the state and county contract will have further detail, as I mentioned, regarding requirements for access, monitoring, appeals, etc. Counties must have a beneficiary access number, which I am assuming must be 24/7. And then coordination with the Medi-Cal managed care plans in the counties. So some counties, you know, and those differ. Some counties will have a single plan. Others that cover everybody with Medi-Cal. Many other counties are two-plan counties, so you will have 2 MOUs to execute. In order to participate, you know, counties have to opt in, so they have to say we want to do it. Otherwise, the state is making this a mandate, which leads to numerous complications. And so the county implementation plan, and that's probably maybe connected to the contract between DHCS and Waiver counties, must ensure that providers are appropriately certified for the services contracted, implement at least 2 evidence-based practices, trained in the ASAM criteria, and are participating in efforts to promote culturally competent service delivery. So this is, the county has to ensure this, but basically this is provider level responsibilities. They're the ones who are going to have to do this. At least in counties where there are, you know, medium to large counties which contract with community-based organizations. Other county responsibilities will be coordination with the drug Medi-Cal providers, again to ensure culturally competent services, that medication-assisted treatment is available to all who may need it, that evidence-based practices are being utilized, and you know, and we have. I should have 3 bullets under there, but you know, we have evidence-based programs, you know, like Matrix, Seeking Safety, which have a curriculum for a whole, you know, the whole thing, and even those, as the Matrix developers will admit, are not necessarily all-inclusive, and there's still a need for individualized treatment planning. There are then evidence-based counseling methods and techniques, cognitive behavioral therapy, motivational interviewing, etc. And then thirdly, which is not on the slide, but you know, it comes down to ultimately, and this is the work we do. You know, it's one person helping another, and it's the skill and abilities and wisdom of the counselors who are working within this best practice, evidence-based practice structure. And that requires, you know, training and oversight and fidelity management. You know, I think I'll have time to talk about that briefly. So anyway, what does it mean? It's first off, an expanded and more directive role for counties in provider oversight, both in terms of medical aspects, in terms of, you know, medical necessity, fiscal, you know, the financing, through rate setting, utilization, and quality improvement. You know, counties, and there are a few counties who do something like this now, but they would have a central or perhaps regional access hubs where clients could be screened, assessed, and placed in treatment, that this placement would be monitored to ensure that they are in the right level of care at the right time in their treatment and recovery process. And maybe not everybody needs 90 days of residential care. And you know, maybe it's 30 or 60 days, and then they can move out to intensive outpatient. But just by way of example. So there's also more directive role in county, as I was just describing, in county client access to and movement through the treatment system. Also, there'll be more data to collect, report, and analyze. And this, you know, I say this is kind of county-centric, but of course this all rolls down to providers in many cases. Data will be required for the evaluation. This will be done by our colleagues at UCLA. They want to the absolute extent possible, use existing data sources, you know, calomes, but you know, other data may be required. Counties need to monitor access, assess the impact of cultural competence measures, and as I see that, I mean, that's looking to see what's, I mean, the structure I would use would be to see, you know, what's the county population, what's the, you know, the demographic segments, are those people accessing treatment at least in proportion to the representation of the general population, and I think most importantly, are they achieving the desired outcomes at the right proportion. Counties also need to support the quality improvement process, which of course focuses strictly on providers, and then to monitor provider performance and client outcomes to support the selective contracting process. You know, if providers are selected, and this oftentimes doesn't happen when county does RFPs. You know, when anybody does an RFP, you submit a proposal, you get the money, and the proposal disappears. You know, in this case, a proposal would be a plan, would have other, it could, you know, have other details, and basically people get funded or they become enrolled as a provider on the basis of the representations made in that proposal, and those would become elements in a quality management plan. But that's one way to do it. A need for more and different staff at county and provider levels, you know, physicians or other licensed practitioners in the healing arts, so that, you know, aside from medical LPHAs, this would also include people like LCSWs and MFTs. A likely need for licensed staff to do youth treatment and family therapy, for example, MFTs. Possibly other, you know, need for clinical supervisors, billing clerks, data analysts, data entry clerks. And there's no, you know, I don't have a crystal ball here, but it's just looking at ahead, you may, you know, that there may be needs for different staff, not necessarily new positions or new people, but, you know, maybe a slightly different role for some staff, existing staff. I think I will actually have time to do this here today, but just when we talk about evidence-based, yes.
Victor, when did you want to, you said you were considering doing some questions in the middle, or do you want to keep going, or, because there's a bunch of questions.
Well, we could do, why don't we do that then? If we have questions that have come in, then let's answer those.
Okay, yes, because some of them are getting from a while back, so that'd be great.
Oh, all right, sure. All right, we'll pause for questions, and then what I want to get into just is the slides on motivational interviewing, but the message has to do with how do we implement evidence-based practices and the implications that has within the waiver. So, okay, well, let's go to
Okay, so the first one was about is campus-based residential treatment allowed through the waiver, or is it still only allowed at a certified facility?
Now, I'm not sure, you know, in the licensing regulations, what I think is meant by campus-based or what the licensing application regulations call integral facilities. So you've got multiple buildings, and so yeah, they would still apply. I mean, this is not going to change the licensing rules for residential treatment. So,
Okay,
so if I understand the question correctly.
Yeah, and if not, the questioner can send us
yeah, they could
follow up. Okay, and then let's move on then. Then we have, please repeat the number of hours for ODF and IoT per week.
Okay, ODF is fewer than 9 hours. and it's for adults, fewer than 6 for youth. And then IoT is anything beyond that level. So intensive outpatient is 9 to 19 hours for adults, or 6 to 19 hours for youth.
Okay, great. Thank you, Victor. Yeah, that's why I wanted to see if you could take a break, because some of these refer to stuff from earlier in the presentation.
Oh, no problem.
We have another one that says, when establishing medical necessity, will that still be done by review of the treatment plan by a physician? Will counties, as part of the centralized screening and assessment, have to provide the physician to make sure referrals meet medical necessity? Or would that happen at the provider or place of authorized services after screening assessment by a certified or licensed staff person? Since the treatment plan currently happens at providers, or will the centralized screening assessment also need to include doing an initial treatment plan?
Boy, well, there's a lot of, that question covers a lot of territory.
I can break it up again. I didn't know if it was all related, but I can break it up and say the first one is, when establishing medical necessity, will that still be done by a review of the treatment plan by a physician?
That will still be done. My understanding is that could also be done, and this could change, by the licensed practitioner of the healing arts. I think the and some of these, but yeah, the programs will need to have a physician, and establishing medical necessity will be a program level requirement. Now, the county might, and this is a good question. I don't really know. I mean, I don't think we know yet. That's to be established. The relationship between, if the county has, an access unit, whether they would make the initial placement recommendation, but leave the treatment. I would expect they would leave the treatment plan up to the provider. They could go through an ASAM interview, and in some cases this may be done on the phone. I mean, I know mental health plans are doing that now, that they will have phone lines.
Yeah, and I think that's what part of the question was, if the counties are doing the screening to make referrals, they need to have the physician to establish medical necessity before they do the referral, or
well, yeah,
would that happen at the provider, once the client got there?
Well, I suppose there would be. You're right. I mean, there is kind of this. Well, I don't. Again, this is to be developed. Either a physician could be involved in that. I think probably not. But on the other hand, then if that's the case, you're talking to somebody over the phone, and again, I think the mental health plans have procedures for this. And the client shows up at the provider and finds out a little bit more about them. Since they're now talking to a live human and not somebody on a phone. And it could be they need a different level of care. Or maybe they don't need substance use treatment at all. It's tough to say. I mean, it requires, I think, a lot of coordination and the definition of roles and responsibilities between establishing between the role of the county and the role of the providers in this. Mm-hmm. And like I said, it's going to be a much different relationship, much more tightly integrated relationship, not only between counties and providers, but among providers as well.
Okay, good. And then another question is, hold on a second. Okay, now specific to methadone, would counties be doing the centralized screening assessment? So it's the same questioner asking another question. Would counties be doing the centralized screening assessment for that level of care as well?
If they do that, yes. It would be every level of care, and counties have to provide a continuum, this full continuum. And so whether it's methadone or Suboxone or other medication-assisted treatment, that would be part of it. Now, again, I think there's a limitation to how much the county can do here. There's also I think, an issue that we do not want this screening or assessment or placement process to be a barrier to access. I think we need to get, you talk to somebody on the phone for an hour and a half, and then, okay, we get your appointment in 2 days, and, blah, blah. That may not, clients may not like that. So, with all of this, having said all of this, we need to make sure that clients can access treatment as quickly as possible.
One of the related questions that the questioner asked was whether counties might be able to contract out the screening assessment.
Oh, of course.
That level of service.
Yeah, there would be, yeah, absolutely.
Okay. All right, then we move on, and we have, it's a question about selective contracting. Does it have to be an RFP, or can it be through a recent RFP process that we deemed eligible for other funded SUD services?
Well, I think, again, this is all, the details on this are yet to be determined. I would think it depends, how recent. Is it for Medi-Cal reimbursable services? Does the RFP include questions that are relevant specifically to the waiver, to drug Medi-Cal requirements and waiver requirements? We talk about performance and quality standards. Hopefully these will be statewide standards instead of 58 individual county standards, but we don't know yet. So I would expect if it's reasonable, well, I don't know. It's reasonable to expect that. Whether or not the state or federal regulations will allow it is another question.
It's probably a question for the state to ask at the time.
Yeah.
To ask of the state. I'm thinking, okay, another one is when you mentioned medication services relative to outpatient treatment, the residential treatment centrally stored medication activities also fall under this service dynamic. Well, yes. Again, as I mentioned before,
Title IX isn't changing. The state licensing standards for residential programs, as far as I know, aren't changing because of the waiver. And so the requirements will still be the same. We have non-medical facilities, and if clients have medications, those are prescribed by a physician external to the program. And if they come in with those, then the centrally stored medication thing comes into play.
Okay, we have another question on intensive outpatient treatment. Can the 6-hour week be 3 groups at 2 hours per group?
Well, I don't know. Right now, groups are defined. This gets into aspects of the system. Now, drug Medi-Cal is defined through a whole bunch of different elements right now. So we've got the state plan, we've got Title 22, we have a drug Medi-Cal billing manual, we have state budget and cost reporting requirements. So right now, a group, we're billing on a unit of service basis, not on units of time. And we are also, those units of service are predefined. An individual session is 60 minutes, a group is 90 minutes. So unless that group definition changes, or the maximum duration of a group changes, we still have the 90-minute requirement.
Okay. But the 6-hour week can be, how about the other element of this question in terms of what can be provided during the 6-hour week?
Well, I think anything is possible.
Anything's possible. Or is that what you said?
No, anything, no. Well, I said, well, at one level, yes, but what I said was anything that is billable.
Billable. Okay, got it.
Yeah.
Anything that is
You could do
billable that adds
others.
up to 6 hours, right?
Yeah. Now, you could maybe do yoga classes, and those, I'm guessing, would not be reimbursable under drug Medi-Cal, under the waiver.
Right.
So it's 6 hours of treatment services, and you could do other, like I said, you could do other stuff if you want.
Okay, now is there, we've had a question, we also saw a question sent to us earlier, and this one matches. Is there structured timeline for implementation? So we're kind of want to get a sense of the timeline around all of this.
Well, I tell you, if this is approved as is from CMS, or if CMS suggests changes that are the state has no problem with, then, the starting gun goes off, second or third week of March. Let's say third week. How soon this all gets implemented, can start to get implemented. I mean, there's now I know that the state is working on a lot of this stuff, but counties have to prepare a plan, prepare a transition plan if they need to add elements to the continuum, if there's any missing pieces. I talked to some large counties, and they say, well, we do an RFP. That's 9 months if nobody appeals. It takes 6 months to get a contract through the Board of Supervisors. So that there's a lot of stuff that has to happen before you turn on the waiver the waiver sign, and that is difficult to predict. So when counties can actually start billing for these new services,
right,
with all the preliminary work that has to be in place, how much the state will accept as you're good enough.
The part that we do know is that the waiver has been submitted to the feds, and it's a 120-day window, right? Is that right?
Yeah.
And
yes.
that will end at the end of February?
No, I believe it's somewhere in the middle of March.
Middle of March will be the end of the window. So by that time,
somewhere in there.
So what is known right now is that by that time we will hear from the feds whether the waiver is accepted or not. And that's about as much as we know now, right?
Yes. That's true. Then everybody gets real busy.
Yeah. Then at the point it is, then work continues to move forward in terms of implementation. Okay. I had some other related questions. One was when will DHCS accept revised protocols? And maybe the follow-up question might help explain that. It says, I have read the emergency waiver language and am clear about those changes. Would I fold those changes into the existing protocol but leave areas the waiver language did not address, assuming it remains the same? For instance, discharge planning. So a new protocol would reflect the changes, but we would retain the material that the regulations were silent on. So that they kind of want to know when will the protocols be revised, but also what happens with the areas that are not talked about in the waiver.
Well, see, again, kind of like residential treatment, if it's not in the waiver, it's business as usual. Assuming it's business as usual now, so drug Medi-Cal, there's going to be some standard elements that are not going to change, and there's probably going to be a fair amount of new information that may be required, particularly in the protocol. But I can't recommend that anybody take any action if they've got an active application in, that they modify that, revise that to be consistent with the material that's currently available regarding the waiver. That could all change. I mean, I don't think we're going to see dramatic changes, but we don't have the details on that. So I would not recommend changing anything until there's direction from the state to do so.
Okay, that fits another question that just came in. It said, right now, in providing drug Medi-Cal services, we must stick to current regs and emergency regs recently adopted.
Yes.
Yes. Okay. And then someone else on a related note was saying, will there be more information regarding county requirements to implement the waiver? If so, when? I think you were kind of addressing that, but maybe you could say just a tiny bit more.
Well, again, I think once the waiver is approved, there are two elements here. That there will be now I don't know whether it's a whole separate contract or an addendum or exhibit to the existing drug Medi-Cal NNA contract between DHCS and counties, but there will be contractual language, one way or the other, that binds counties to the terms and conditions of the waiver, as well as any other changes that the state might make. And for example, these would be, if there were changes in Title 22. Well, no, they can't change Title 22. But that's the kind of thing. So that whatever the requirements are going to be, those will be passed down to counties in the through some sort of contractual mechanism. It will refer also to the county's implementation plan, which I'm sure will need to be approved by DHCS, may need to be modified on initial review by DHCS. So again, lots of specific operational details we don't have yet.
Victor, I think maybe one of the important points to make here, I think, by the gist of some of these questions, wondering when is this all coming to play, I think it's reminding people that this is an opt-in program.
Correct.
So that these changes will not impact you at all. I mean, I'm being exaggerating a little bit, but they will not really have an impact unless and only at the time of which your county opts in.
That is correct.
And so then, Victor, what you're saying is that, and then when that happens, in the process of opting in, all this will get clarified through contractual language, et cetera, et cetera. So,
it will have to be.
Yeah. So, but for those who are wondering, when does this take effect? It will not take effect until the county goes through the process of opting in, and then you'll find these questions should be addressed. In that process.
Right. Now, see. So CMS approved this in third week of March. I don't know that I don't know what the state's been up to. I know they've been busy on this, but whether anybody be ready to go as of July 1st. 3 months to get this off the ground. Maybe a couple counties have got enough pieces of the puzzle in place to do that. I just don't know.
Okay.
And so it's utter speculation when, the implementation date would be, and when counties can start submitting claims for these new services.
Okay. Okay. Great. I think that should help address those questions. And then we had another follow-up on the intensive outpatient. This is now asking about youth. 6-hour minimum. Is that they're assuming that means the youth and not the family time, not collateral. When the family are, but without the youth there, right? So it's not activities that the family does without the youth, but it should be directly with the youth. That was a question we had.
Well, not necessarily. I mean, we still will have the collateral services, so that could be meeting with, which is defined. It's not. You could have the parents there with or without the youth client, and the purpose of that is to engage the parents or significant others. They don't have to be mom and dad. To engage the significant others in the client's treatment plan. You could also then do family therapy in addition to that.
And you're thinking that the collateral, even without the youth present, would count towards the IOP?
Oh, I see. Yeah. Well, this is a level of detail where I could say the current practice is, it is billed as a service in Drug Medi-Cal right now under the client's Medi-Cal number.
Mm-hmm.
You know, so if, and it could be an adult or a youth. You
Mm-hmm.
come in and you meet with the significant people in the life of the client, and you bill for it. It's billed under the client's Medi-Cal number. So unless the state says these 9 hours are whatever it is, you know, 6 to 9 hours are exclusive of collateral, I would think it'd be, you know.
It would be. Okay. One last question. We're all caught up. Where might you find the Drug Medi-Cal billing manual?
Oh, I tell you, we could send that out, the link. It's on the Department of Healthcare Services website. Some people have a little hard time navigating that, and you go to the Drug Medi-Cal page, and they've got 3 links on there, a lot of text, but 3 links talking about certifying, claims processing, and it's the claims or reimbursement link that gets you to the billing manual.
Okay. Well, we're caught up, so you can continue.
Okay. All right. Well, I guess I'll go pretty quickly here. I may skip a slide or two just to see, or Will, you could let me know if the questions come in, you know, hot and heavy. I could, you know, stop earlier.
Okay.
So anyway, this is back to motivational interviewing and the implementation of evidence-based practices. And these are slide content from a CIBHS colleague relative to motivational interviewing, but this applies to anything, or at least any evidence-based practice. That, you know, the thinking is that the training shapes clinician responses, that changes practice behavior and improves client outcomes. You know, that's the model. But we have studies showing that even though trainees show high satisfaction and high levels of perceived gain after a MI workshop, when follow-up is done with those same clinicians, the tape-recorded sessions show only modest changes in practice and no difference in client response. And you know, the conclusion, obvious, you know, is people need more than a one-time workshop, you know, to really be proficient at any motivation, at any evidence-based, you know, treatment technique, whether it's MI or CBT or MRT, whatever. And so they indicate here that, you know, that there are other tools for improving training outcomes. It's individual feedback, personal follow-up coaching. And what I want to highlight here is, you know, the challenge is that they need to, that staff need to persist in behavior change after the initial workshop. And too often, you know, counselors think they may may be erroneously convinced that they have already learned the method. And actually we need to apply motivational interviewing techniques to the people who undergo the training. And this is the challenge for evidence-based practice implementation in general, is that, you know, people will go through a workshop, go through a, you know, 2-day training or whatever, that's it, and they think they know the technique. And, you know, they've got a good grounding, but it takes time, practice, and feedback, supervision to make sure that really takes hold. And the recommendations are, you know, there's a 2-day introductory training. This comes from the developers of MI. You know, a 2-day introductory training, 6 months follow-up coaching, maybe can be done by a webinar, a booster training session, motivational interviewing for clinical supervisors, and training on the use of a motivational interviewing fidelity scale, fidelity measurement scale. You know, fidelity is a part of this. So just to go back to that, there's a lot more to this than going to a workshop or a couple of webinars. And it takes more time and frankly, expense to make sure that these evidence-based practices are learned and implemented in a way that is faithful to the model. And particularly if this is going to go into the evaluation, we need to make sure the people doing CBT or MI or MRT or, what you pick your acronym, pick your practice, is done with fidelity. Because if not, then the ability to have confidence in UCLA's analysis of outcomes is going to be shaky. Finance is a big issue, and this is, I talk about more linkages among providers. I think in an earlier slide or one of the questions, is first off, as a provider, do you know your true unit cost? This is a whole other presentation. What happens in the nonprofit world is, the funding comes and goes. We know all so well. And, you get one contract goes away or the grant ends up, but you keep the staff. They're good staff. You want to keep them. So who's paying for them now? And so the question is, what happens is you get a drift over time in the actual revenue supporting any given position and the units of service that they provide. And if you do not know what the real revenue components are for that service unit and the true cost, you can have trouble negotiating contracts, particularly as we look at the ability, there may be some adjustments in rates. How can you document that? Providers are going to have to and say, this is why we're charging more, why we want more. Here's the value you get for that. And you need to know really what your cost structures really are. And particularly if you move from a volume-based to a value-based reimbursement, say if the county, and some counties do this now, pay a case rate. There's so much for the entire episode of care. Now this makes sense if you're a large provider and you do everything within your four walls or within your various facilities. But if you're a standalone outpatient provider and you're at towards the end of the food chain, if you got detox, residential, and then intensive outpatient, your reimbursement depends in part on what happens in those earlier levels of care. And then how would the county actually do that? I mean, we may not get right out of the gate to volume-based or value-based reimbursement, but it is, I think, a powerful way, again, and it's consistent with the ACA, is moving the financial focus from service units to client outcomes, to client health, quality of life. Briefly, volume-based financing works like this. Money goes in the top of the funnel. It produces direct service staff, the FTEs. That translates down into hours spent in direct service. Many providers and most county mental health systems have productivity standards. You need to spend 50-60% of your day doing billable services. And particularly under this system where drug Medi-Cal is a major source of financing, if you can't bill enough to support your staffing, you're going to have big problems. And so the hours spent in direct service and productivity translates into billable client visits. Value-based sort of looks at this as a different way. These are, at the left-hand end and up at the top, you've got money. This is actually from an actual county. Over the course of the year, they spent $10 million on treatment services. They saw 10,000 clients admitted to their system. And 4,500, according to CalOMS, successfully completed treatment. So with an investment of $10 million over 12 months, we had 4,500 people achieve a positive treatment outcome. And what I suggested to the county substance abuse administrators, what if, for the same 10 million, there was maybe 8,000 clients coming in at the front door, but 6,000, or let's say 5,500, who are achieving successful outcomes in treatment for the same amount of money. Would you do that? Would that be worth doing? And that was, they thought about that a lot. But that's how value-based reimbursement works. So as I mentioned, You know, there's a lot of information yet to be revealed, a lot of operational details, implementation guidelines, etc., that, you know, yet to be developed and made public. There's the financing algorithm, and I quoted George Box, a statistician here, who says that all models are wrong, but some are useful. And when he says wrong, it really means imprecise. You know, they are not reflections of reality. There's going to be ways that they can be adjusted over time to better correspond to the way things work. So this reflects the way the system is organized and operates. Now, if the waiver works as advertised and we get better outcomes and decreased dropout rates, we're going to have more clients staying in treatment longer, then we're going to need to add capacity. You know, our ability to absorb new clients and provide access depends to a certain extent on the dropout rates we have. Somebody leaves treatment, you got an open slot. So we need to be thinking about how that may change things. We become more effective in attracting, engaging, and retaining clients. And also, I mean, for example, if somebody mentioned this to me, you know, if we do recovery support services are effective, then the relapse door, you know, that track into treatment is going to be reduced. If we can help people stay clean and sober in the community. The local rate setting process, you know, their county auditors love to toss around, oh, is this a gift of public funds? Well, no, we got to document higher value here. You know, say, you know, somebody says, well, you're paying this, what is it, you know, $68 per individual session now. We really need 75. Well, prove it, because you're going to have to get not only just to your county substance abuse administrator, but also through the county financial structure as well. They are all aware of the CSAC, the County Supervisors Association, has weighed in on the waiver. You know, county CAOs know about it. Auditor controllers know about it. The CFOs in your health or mental health services know about it. So the decision to engage in the waiver will be reviewed by people outside the substance use and or behavioral health system. Other details here, specifically youth treatment, you know, I think that will come from providers. You know, how we do that. We don't have as robust a system as we could have. The role of the block grant, will that be basically a county by county decision, or will THCS be a little more directive on how the block grant dollars complement drug Medi-Cal? I have to add too that SAMHSA has for a couple of years now had a question in the block grant application that states have to submit that asks what steps they are taking as a state to ensure the block grant funds are expended for non-covered services and for clients who don't have coverage. And that's in the state's going to have to answer that question for the application that's in process now. Well, it's not 120 days anymore. It's less than that. But counties are going to have to be thinking about, you know, selective contracting standards, how they go about recruiting providers, RFPs, looking at financial analysis, financial risk. This is a big issue with counties. They want to make sure that they're not going to run short. A bit of a gap analysis on the needs for what additional data and technology may be required, the type and quality of contractor cost data, which would support rate setting, projecting this regional service coverage that provides, and this is, you know, waiver language here, provides client choice, culturally competent, and will meet county performance and quality standards. And also the need, this is for counties, but to establish key system baseline measures. Again, more rules. Some of this is county, some of this is state, rehab model, service provision rules. You know, these other three items are related to the waiver plan that counties have to submit. And that's it. And so, Will, if there are more questions, that's how you can contact me, and you know, I'll try and answer any questions you may submit. I think we may get back to people with at least the link to the drug Medi-Cal billing waiver. So, Will, if there are more questions, we can...
There are more questions. Okay. Would residential services still be bound by the IMD exclusion?
I would say no. There is the ability to finance residential care in facilities with more than 16 beds, and DHCS is careful to point this out. This is not a waiver of the IMD exclusion. It does allow, it certainly acts like one, but it's because the IMD exclusion has its roots in some in the Franklin Pierce administration. It's been around for a very long time, and we're not going to unravel it in the next several months. So the CMS is saying you can bill for residential treatment in larger facilities, and they don't say anything about the IMD exclusion. So right now, the words IMD are not in the waiver, but the state will reimburse, and CMS will approve that care in residential treatment programs with 17 or more beds.
Okay. All right. Next question. Sorry. I'm trying. Several people have been asking for the link to the drug Medi-Cal billing, and I'm trying to provide that. But let me see. Also, how would you see value-based reimbursement working in medically assisted treatment?
Well, again, it focuses, value-based focuses on client outcomes, and less on the client visit. Now, that doesn't mean you wouldn't pay reimbursed for service units necessarily, but I mean, there's a lot of different ways this can be done. And it depends kind of what the outcome is. And I'm just talking off the top of my head and based on my experience as a county administrator in the field. I would want to see this for medication-assisted treatment, that we would reimburse for that to the extent that it is connected with outpatient treatment. What we've had for a long time is we'll have physicians in the community who may prescribe Suboxone, but there's no linkage of the client to treatment, to substance use treatment. So that would be something that would be part of that. Or for yeah, I mean, there's a lot of different ways you could structure this, and I don't want to just speculate, sort of talk off the top of my head on this.
And we only have a couple more minutes, so.
Yeah, we only have a few minutes here.
Okay, so I think, people were asking for a link. I want you to notice in the chat section, I have sent a link. I have posted in the chat a link to the billing manual, so you can see that. And then, let's see, we had just two more comments. Okay, so one, almost none of this seems to apply to current NTP services, which are largely excellent in quality, if not state-wideness. Why are NTPs not carved out?
Well, actually, I'm not sure what is meant by carved out, but if a client is going to do the full continuum of care, then NTPs, I mean, my understanding what DHCS has said, NTPs need to be a part of that continuum. So I don't see that they're carved out or somehow excluded or something apart. I think they're an important part of the service delivery system.
So the waiver will include or apply to NTP services?
As far as I know, yes, absolutely.
Okay. And then opting in on the waiver will be a formal process, like an application type process, with specific criteria to be met and submitted and then approved? Question.
Oh, question? Yeah, as I understand it, and probably go through the Board of Supervisors, too. I'm not sure.
Yeah.
Yeah, so it'll be a process because, I mean, there's money involved, and I think, in many counties, if you're going to apply for a grant or something, that requires approval from the board.
Yeah, and actually I think you covered some of the elements of that application process, right?
Yes.
The implementation plan and stuff like that. So if people miss that there is already some guidance in terms of what it will take for a county to apply, and I think the actual forms and all that will be created and things like that. But I think they're working on drafts of those documents too.
Oh,
right?
yeah, I'm sure they are. Now the thing is, I mean, you've got to, in theory, I mean, at least the state has indicated that this is a possibility. They're going to review those plans, and your plan may not, a county's plan may be far enough. There may be a big enough gap between their current, current structure and what would be required under the waiver, that they could say, well, why don't you work on this and resubmit next year? Because they're soliciting counties in 4 waves. So they've talked about, a state approval process, which means, implies to me that not all plans would be approved. Now, so I'm not sure whether there would be some guidelines that would be helpful. The counties could see beforehand saying, okay, your plan's got to meet these minimum level of, of access or provider coverage or components of the continuum.
And we're at 11:30, but I have 2 more questions. So I'll have to say these will be the last questions. If people want to stay and listen to them, then you're welcome. Or if you need to get off because you have other, this is a scheduled ending of our webinar. I promise we won't cover any more than these last 2 questions. I'll read them off first so you know what they are, and then Victor will answer them, and then we'll wrap up our webinar. So the first one is, can a NTP program expand their activities to such things as case management under the ODS? And then the second question is, will a methadone client be able to receive a prescription at meth clinic and outpatient treatment at another facility? So those are the 2 questions that we'll be tackling, and then we'll be closing the webinar. So Victor, do you want me to repeat the first question?
Yeah, just quick.
Yeah, can an NTP program expand their activities to such things as case management under the ODS?
Well, see, I guess there's a question there, and again, we don't know for sure. One, although I don't see this happening, although it could, whether any NTPs are also certified to do outpatient counseling and bill for outpatient counseling, number 1. And again, like I say, the existing rules, Title IX for NTPs is not going to change. But then also for case management, we don't know yet whether that's going to be, how that's going to be operated. If that's going to be only provided as a component of outpatient treatment, or could it be a service that any certified provider could do? And so, like I said, we don't know. It depends how the state. There needs to be further definition on that. I think that's a good point and something that ought to be reimbursable for any provider. Everybody needs case management. Well, almost everybody, and all providers should be able to provide that and get paid for it. But we don't know yet.
Yeah, and they're not necessarily listening to you.
Who? The state?
I mean, the state isn't necessarily going to do business.
Oh, yeah, no, they, unfortunately, no, I'm not governor yet. So
Right. I just want to make sure everyone in the audience understands that was just your personal opinion. Yeah.
Exactly.
Okay, and then last one was the one about, will a methadone client be able to receive a prescription at a meth clinic and outpatient treatment at another facility?
Boy, that's a good question. I think there are two levels to that. One, there was a question, I believe it was at the Waiver Advisory Group meeting a couple of weeks ago, where somebody asked, well, if a client's in outpatient treatment, could we bill for a group and a case management session on the same day? And the state said, that's a good question. They wrote that down. And, billing for two services on the same day has been a real, is not allowed in most cases. It's been a challenge for a lot of providers, not in healthcare as well as behavioral health. So that's the first dimension. And then the other is, and again, talking about, the rules, many of the rules in place are going to, will continue. Title 22 isn't going to get rewritten for the waiver. I mean, there may be other changes. And so what the state has seen is that, current modalities, whether it's clients in outpatient or residential or NTP, have been historically considered to be all-inclusive. So, if a client is in, well, as it happens right now, if a client's in, in an NTP and is also participating in outpatient treatment, only one provider is going to get paid. So there's also a billing rule on top of it. And I go back to the statement I made before, like there's a lot of elements, different elements that define how drug Medi-Cal works. So there's billing rules. There's also the state's administrative policy saying, we pay for counseling in the NTP setting. We're not going to pay for it simultaneously in another setting. That's double dipping or something along those lines. So this could change. I don't know. But I'm just saying the reason the way it is now is what I've just described, and those circumstances need to get modified for counties and providers participating in the waiver.
Okay, so the questioner replied, thank you. So thank you, Victor. I want to thank you as well for taking your time to walk us through what is known so far about the waiver. And we will send information about, we've sent everyone who has registered a PowerPoint. Some people have been asking us about the slides, so either somehow there was some error in sending it out to you. So if you feel free to follow up with us if you want the slides. And then we will, once the material is posted, we will send you the links to the material once it's posted, and as well as a schedule to the upcoming webinars, which will be addressing different aspects of the waiver. So we thank you all for your participation, and and again, thank you, Victor. And I think that's it. Did you have any last words that you want to say, Victor, before we close?
No, I would just like to thank everybody for hanging in there and to track this. I think this is a change in the field of really monumental proportions. It's not something we've seen since probably for like 25 years when the Reagan-Bush drug war money started rolling in. There's enormous potential to improve services and to improve client outcomes. So I encourage everybody to be a frequent visitor to the DHCS website to stay informed. And thank you once again.
Great. Okay, thank you, everyone. Bye.